Hi, welcome to NEET PG Core Revision series in Pharmacology, where I am going to talk about the most important topics for the upcoming NEET PG examination. Today, we are going to discuss the topics in psychopharmacology. So, let's first go and understand the important questions from the topic of antidepressants. So, the antidepressants, the first group that we're going to do is SSRIs or selective serotonin reuptake inhibitors. So, you know what they do? The mechanism is that they inhibit the 5-HT transporter. That's how they're going to increase the level of serotonin in the synaptic cleft. But you know, this is a slower action. The response will take about 4 weeks. So, response takes about 4 weeks. Right? So, these are the drug of choice for depression these days. Depression, and they're also used for obsessive compulsive disorder and generalized anxiety disorders. Which of the SSRIs is the longest acting and hence has the least withdrawal phenomena? So, we have the drug that is fluoxetine. Shortest acting, teratogenic and with maximum withdrawal reaction, we have paroxetine. Preferred in pregnancy, we have sertraline and escitalopram. For premature ejaculation, we give the drug depoxetine, right? Depoxetine. In the adverse drug reactions, the most common adverse effect which we see with this is nausea, and this is due to 5-HT3 receptor stimulation. Due to the stimulation or because it is increasing the serotonin levels, therefore is acting on the various serotonergic receptors. So because of 5-HT4 receptors in GIT, you know, this is involved in the prokinetic action. So it is going to cause loose stools. Now due to 5-HT2 stimulation in the brain, it can cause anxiety and it can lead to insomnia. Now, due to 5-HT2 stimulation in the spinal cord, this is associated with sexual dysfunction, right? And it can also lead to delayed ejaculation. Serotonin syndrome, it is a syndrome when there is increased level of serotonin, and this can occur when you give this kind of drug with other groups of drug which also increases levels of serotonin. So which are those? For example, tricyclic antidepressants. They also are going to increase the level of serotonin. Then monoamine oxidase inhibitors. They are going to inhibit the metabolism. Then we have a drug called as antibiotic. We have linezolid. That also increases the serotonin levels. Then we have triptans. Right? These are the agonists at the receptors. Then we have tramadol. It also increases the levels of serotonin, right? So these are the drugs with which we can see serotonin syndrome. And what is the treatment of serotonin syndrome? Obviously, you have to stop giving the drug. But what else can you do? So you stop a drug, stop the drug, and you can give a serotonergic antagonist. So we can give cyproheptadine, right? All right. Moving on to the next group of drugs we have is tricyclic antidepressants. Now, these drugs, their response varies from individuals. Therefore, this is a group which is a candidate for therapeutic drug monitoring. So, we have a drug here, clomipramine, and another is imipramine. So, clomipramine is given in OCDs, imipramine is given in nocturnal enuresis. Now, tricyclic antidepressants, their role is to inhibit the reuptake of 5-HT as well as the norepinephrine. But not only that, it also leads or it acts on the various other receptors and blocks them. So the side effects are basically because of the blockage of those receptors. So for example, if it blocks the cholinergic receptors, muscarinic receptor, it has anticholinergic side effects. So it can lead to dry mouth, it can lead to constipation, it can lead to urinary retention. So because of this, it is contraindicated in patients, elderly male patients who have benign hypertrophy of prostate. Because of alpha blockers or alpha blocking effect, it can lead to postural hypotension. Postural hypotension. Histamine receptor blockade can lead to sedation. No, all antihistamines, they are sedative, so it can lead to sedation. It can lead to weight gain. Now, increased serotonin, that has a tendency to increase the appetite as well. And this can contribute a little bit to the weight gain. Now, overdose with TCAs. So, what happens because it leads to acidosis. So, therefore, the treatment should be by giving an alkaline agent. So, here the treatment is sodium bicarbonate. Now, it can lead to some of the atropinic symptoms, like because anticholinergic, that is the predominant symptom. What you do, you give a drug which is given in atropine overdose. So, for example, you give here physostigmine. So, you give physostigmine. For arrhythmias, what happens because it can lead to QT prolongation and for arrhythmias. So, what is the best? You give an antiarrhythmic like lignocaine. Lignocaine. Then we have SNRIs, which is selective norepinephrine reuptake inhibitor, right? So, what is the role of this? So, we have venlafaxine, desvenlafaxine, duloxetine, reboxetine, and milnacipran. So, remember here, out of them, duloxetine is the longest acting and it is used in stress urinary incontinence. Reboxetine is used in ADHD. Now, these drugs, they are contraindicated in case of cardiac disease because they are inhibiting the norepinephrine reuptake. So, there will be increase in the norepinephrine levels, which can trigger the receptors in the heart, the beta 1 receptor. So, therefore, already if there is a cardiac disease present, then we should not give this drug, cardiac disease. Then some newer drugs. So, what are the important points you should know about these newer drugs here? Is the first drug we have vortioxetine. It is called as MSSA, MSSA, which is multiple serotonin agonist antagonist. So somewhere it is agonist, somewhere it is antagonist. It is called as MSSA. Then vilazodone, it is called as PARI. This is serotonin partial agonist and reuptake inhibitor, right? So another important point about this drug is that it has no ejaculation issue, right? So no erectile dysfunction, no erectile dysfunction. Esketamine is a drug which blocks the NMDA receptors, and this was a question, just used as nasal spray, available as a nasal spray in case of resistant depression. Brexanolone is a GABA receptor modulator and it is used for postpartum depression. So these are some newer drugs and their mechanisms of actions. Okay, now moving on to the atypical drugs and what are their important side effects which you should be aware of. So bupropion, very important. It is a norepinephrine and dopaminergic reuptake inhibitor. Its main use we have done in smoking cessation. Smoking cessation. Major side effects that this drug actually brings down the threshold for seizures. So it can cause, in high dose, it can cause seizures and it can lead to anxiety as well. Mianserin, it blocks the presynaptic alpha 2 receptors. So the alpha 2 receptors which are present presynaptically, it will block these receptors. So what is the alpha 2? You remember alpha 2, these are like the brakes. So when you're blocking them, there'll be increase in the release of norepinephrine. That is important. Again, it can predispose the person to seizures. Amoxapine, important. Amoxapine is very amicable drug. So it is causing the D2 block and inhibits the norepinephrine uptake. It has this special action. Mirtazapine, remember this is called as NASA. Remember we have done NASA, which is vortioxetine, but NASA is mirtazapine, right? So M is repelling each other. So M will come with N. Mirtazapine is NASA, not MASA. Okay? So MV, you remember that is, and this is MN. Mirtazapine. So what is this? This is noradrenergic and specific serotonin antidepressant. So affects certain specific serotonergic receptors, right? So it is norepinephrine or adrenaline and specific serotonin antidepressant. Now, mirtazapine has a very important property. It's a very sedative drug. And it can increase the appetite also. So therefore, where do you use them? Therefore, used in case of depression with insomnia. And also, let's say patient is losing weight, then also it is helpful. So it will lead to weight gain also. So if there is depression with insomnia and weight loss or loss of weight, so this is a very good drug to be given. And it is usually given at night so that patient can sleep well. Then we have nifazodone, which is causing the 5-HT2 block. Now this is a hepatotoxic drug. Hepatotoxic drug. Now trazodone, very important drug. So trazodone means 3. So it does 3 things. What? Number 1, it blocks the 5-HT uptake. Number 2, it causes alpha. And number 3, 5-HT2 block. Remember trazodone. So this is also called as SARI. We had a SPARI, right? Vilazodone was a SPARI and this is a SARI. So that was a serotonergic or serotonin partial agonist and reuptake inhibitors. This is serotonergic antagonist. It is blocking the 5-HT uptake. So it is serotonin antagonist and receptor inhibitor and reuptake inhibitor. It inhibits the reuptake as well. So it is increasing the basically HT5-HT levels, but it is causing the alpha and 5-HT2 block as well. So this is SARI, right? So this is very important. And what else is important here to know? That's the side effects which are asked usually, that this is a drug which can cause priapism. It is no longer used actually because of this, the priapism. And what else is important? It can cause sedation. And because it is blocking the alpha receptors, it can cause postural hypotension as well. Postural hypotension. So this is SARI. Let's highlight these important ones. Then this is NASA, which is mirtazapine MN, right? Then here we had SPARI and we had MASA. So these 4 terms you should know. MASA is vortioxetine MV, vilazodone is SPARI, trazodone is SARI, right? So Nassa is mirtazapine. M with N, not with M. So M will always be followed by N. So mirtazapine is Nassa, and vortioxetine is Nassa. Vilazodone is Pari, and this is Sari. And it is trazodone. So three things. It blocks the 5-HT uptake, alpha, and 5-HT block as well. Okay. Now, again, another one here. Let me tell you about the MAO inhibitor, which are also antidepressants, monoamine oxidase inhibitors. Only thing to remember about the side effects, it can cause cheese reaction. So, if you give it with other drug or food which contains tyramine, then it can aggravate the cheese reaction. So, what is the treatment of this cheese reaction? Is given alpha blocker, which is phentolamine. Okay. So, let's do this MCQ here. A 45-year-old patient with a history of depression was initially being treated with sertraline, but the symptoms were not adequately controlled. His medication regime was changed to include a monoamine oxidase inhibitor and amitriptyline. So there was MAO inhibitor and amitriptyline. So shortly after the change in medication, patient developed agitation, seizures, hyperreflexia, and tremors. Which of the following is the most appropriate treatment for this patient? So basically, what is happening is amitriptyline MAO inhibitor. So both of them, when they are given together, there is increase in the level of serotonin. So this high level of serotonin leads to a condition called as serotonergic syndrome. So these are all the signs and symptoms of a serotonergic syndrome. There is agitation, seizures, hyperreflexia, and tremors. So I told you when there is serotonergic syndrome, what is the best thing you can do is you can block the 5-HT receptor. So here, one of the 5-HT antagonists we have to look out for. So the drug here is cyproheptadine. Because what is flumazenil? It is a benzodiazepine antagonist. Okay. What is L-carnitine? It is a valproate antagonist. And what is leucovorin? We give leucovorin rescue. This is for methotrexate overdose or toxicity. Right? So, cyproheptadine is the correct answer for us. Moving on to the antipsychotics. In the antipsychotics, we have typical and atypical. In the typical one, we have chlorpromazine, thioridazine, fluphenazine, haloperidol, and droperidol. Now, again, these typical antipsychotics, the main role is that they are only actually, or the main effect is because of the blocking of the D2 receptors. And because they block the D2 receptors, what they lead to is they only actually treat the positive symptoms well. So, there is treatment of positive symptoms. Now, because of D2 block, the major adverse effect which is seen with this drug is extrapyramidal syndrome, and there is hyperprolactinemia. Okay. Now, they also block the other receptors. So, just we've done like the way we did in tricyclic or in the antidepressant, similar action here. What if H1 is blocked? So, if H1 is blocked, what side effect can occur for us? It is sedation. If alpha 1 is blocked, it can lead to hypotension. If muscarinic receptors are blocked, it can lead to dry mouth, constipation, and another one with us is urinary retention. Right? Also remember that such drugs can trigger the attack of glaucoma as well, right? Why? Because anti-muscarinic action, right? Muscarinic action would be causing the meiosis. So the anti-muscarinic is called mydriasis, can precipitate an attack of glaucoma as well. Now, where do we use droperidol with fentanyl? It is used in a condition that is called as neurolept analgesia. It's analgesia. Chlorpromazine is also used in case of, apart from the antipsychotic effect, it has a role in intractable hiccups. It is not getting treated. by any other way. So this is called the intractable hiccups. We can use them. Major problem with these groups, typical or atypical, is metabolic syndrome. So there is a mix of diabetes, hyperlipidemia, etc., weight gain. So which are the drugs which show maximal metabolic syndrome? So out of the typical ones, we have thioridazine, maximum thioridazine. While the most potent out of this, the typical haloperidol is considered to be the most potent. But the most potent ones are least likely to cause metabolic syndrome. So least is with haloperidol. Now, apart from thyroidazine, the atypical ones, they are known to cause metabolic syndrome. The two major drugs which are important here is clozapine and olanzapine. Then, which drugs have no tendency to cause weight gain? So, one we have aripiprazole and ziprasidone. Okay. Now, very important now is atypical antipsychotics. More important than typical, we have atypical antipsychotics. We know that their main action is to cause the 5-HT2 block, and this is responsible for decreasing the negative symptoms which are more difficult to treat. Decrease in the negative symptoms like apathy, the patient is secluded, withdrawn, and there's emotional flattening. They are very, very difficult to treat. So with typical, actually, they are not. In typical ones, the positive symptoms like there is delusions and hallucinations, agitation, that is treated. But the negative symptoms are less effectively treated with the typical antipsychotics. So here we have the 5-HT2 blockers, which are the atypical antipsychotics. They have more effect on the negative symptoms. Right. So some important atypical antipsychotics, and this is the most important antipsychotic for examination point of view. One is clozapine. So clozapine, this is used for resistant schizophrenia. Resistant schizophrenia, drug of choice. Right? Why only for resistant and not for the routine? Because it has a lot of side effects. So what are the side effects? You remember a mnemonic, SAM. Not same, SAM. So SAM, S is for seizures. Now this is a dose dependent effect. So when you go on increasing the dose, the threshold for seizure goes down. Then A stands for agranulocytosis. Agranulocytosis. Now this is not dose dependent. So you can say dose, here we write dose dependent, and here I write dose independent. So this can occur in anyone in any dose range. So therefore, you need to monitor the WBC count, right? So you have to weekly monitor the WBC count. So M stands for myocarditis. S stands for cyalloria, or also called as the wet pillow syndrome. And it also leads to sedation. So 2 here, S is sedation and cyalloria. Then A stands for acute congestive glaucoma. And the last M stands for metabolic syndrome. So you can cause metabolic syndrome. So metformin can be used in this case. So these are the important points to know about clozapine. It is used in resistant schizophrenia, and what are the major adverse effects. Now risperidone, out of the atypical drugs, has the maximum risk. Risk of what? Maximum risk of causing the D2 block and therefore causing EPS and hyperprolactinemia. So which of the atypical antipsychotics has a maximum tendency to cause EPS or the hyperprolactinemia. It is risperidone because it has maximum D2 block effect as compared to the other atypical antipsychotics. So it is used in OCDs. Then aripiprazole. Now aripiprazole, what is important here is to remember it is a partial agonist at the, apart from this, it is a partial agonist at D2 and 5-HT1 receptors. So, right, it is a aripiprazole. So, it is a partial agonist PA at the D2 and 5-HT1 receptors, and it has least tendency to cause weight gain, so, and less tendency for weight gain as well as EPS, because it is a partial agonist at D2. Remember, because of the partial agonistic activity, less tendency to cause EPS. Alright, then we have pimavanserin. What is important about pimavanserin? Now, pimavanserin has no D2 blocking action. So, it causes no D2 block. So, what will happen therefore? There will be therefore no risk of EPS. So, where can you use them? In case of Parkinson's induced psychosis. Induced psychosis. Why? Because it will not block the D2 receptor, because all the other drugs are going to block the D2 receptors and they will further aggravate Parkinsonism. But because it has no effect on the D2 receptors here, this drug can be safely given in Parkinson's induced psychosis. Right? So, this is the drug of choice here. Levosulpiride is a drug which also has a prokinetic action. So, which antipsychotic also has a prokinetic action? This is levosulpiride, prokinetic action. So, we can use it in gastroesophageal reflux disease. Alright. So, moving on to the important points here on the EPS. This is very, very important. So, what is important? Different types of extrapyramidal symptoms that we can see, and what is the treatment. Now, the first one is acute dystonia occurs earliest, right? It is earliest to occur. And there is, you can say, sudden movement. So, what is in dystonia? There is spasms. So, there are spasms of neck or the eye muscles, right? And or what is this called as torticollis or oculogyric crisis. All this is called. So, earliest to develop, and what is it because of? Because there is D2 block. So, when the D2 gets blocked, there is enhanced activity of the cholinergic part. So, we need to give some anticholinergic which are centrally acting. So, we have centrally acting anticholinergics like benzhexol. So, this is the drug of choice, benzhexol. Or because this is not very readily available, we have other antihistaminics readily available in the hospital which also have an anticholinergic action, so we can give them also. So, we have promethazine. It is an antihistaminic but also has an anticholinergic effect. So, promethazine. Akathisia. Now, akathisia is one of the most common, you can say, the EPS. And what happens here, the patient is restless. He moves about here and there and without sitting at one place. Even if he is sitting at one place, he'll be moving his legs. So, he can't sit still. So, patient is restless, patient is anxious, he moves around, right, to and fro. So, this can be treated with a drug which will bring down his anxiousness, anxiety. So, here the drug of choice for us is a beta blocker, propranolol. That is the first drug to be given in such case. Then we have Parkinsonism. So, this is because of the drug-induced Parkinsonism, right? So, here what happens if you give levodopa, it will not be effective because here D2 receptors, they are blocked. So, levodopa is going to eventually give out dopamine, and that dopamine is not going to act on the receptor because the receptor is blocked. So, what you do here is in Parkinsonism, because there is a balance between the dopaminergic and the cholinergic activity. So, if dopaminergic activity is going down, you will see relatively the cholinergic activity will be much more relative, you can say it is much more higher. So what you do here is the tremors and everything which is happening here because of the cholinergic overactivity. So you bring down the cholinergic overactivity here. So here in Parkinsonism, what is happening here? It will be the rigidity, there will be tremors which are important, right? Rigidity and tremors, these are important, and because of this, you need to give again benzhexol, right? So again, benzhexol is important in rigidity and tremors. Even there will be decrease in the movement, which is called as bradykinesia. Then we have tardive dyskinesia. Now, this is different as compared to the others. Now, all the others were because of dopamine block. Now, this tardive dyskinesia, which occurs very late after years of the treatment, even sometimes after stopping the therapy, after years of treatment. So, what is happening here is this is because of the dopamine receptor supersensitivity. So receptors become super sensitive because initially you have been giving these antipsychotics which are blocking the D2 receptors. So continuous pressure of an antagonist, what happens is they increase the dopaminergic sensitivity. So what was happening here? So this is the presynaptic neuron. So here there is dopamine. So right. So the receptors, the D2 receptors here, because they are blocked by these drugs. So over a period of time, there will be enhanced or super sensitive upregulation also of these dopaminergic receptors. So when there is dopamine release, so even after years what will happen when the even smaller amount of dopamine which is released, it is going to act on these receptors, extra receptors, and this is going to lead to dyskinesias. Now, what is the best thing to do here is you have to decrease the effect of or decrease the release of dopamine. Now, in this vesicle, this is a storage vesicle here, we have transporters, which is called as the VMAT, vesicular monoamine transporter. Now, this is a VMAT2. So, this is responsible for carrying dopamine inside the storage vesicle. If dopamine lies outside, it will be metabolized, right? This can be metabolized if it is outside. For it to be there as such, it needs to get stored in the vesicle. But if you block the VMAT2, so what you do, you are going to block the VMAT2 here. If you block this VMAT2, so dopamine is not going to be stored in the vesicle and not going to be released, but it is going to be destroyed here. That's our aim, because we want to decrease the release of dopamine here so that it is not able to act on the super sensitive or the upregulated receptors. So what is the best thing we do? We give VMAT2 inhibitors. So you give VMAT2 inhibitor. So here the drug treatment is different. VMAT2 inhibitors. So we have tetrabenazine, deutetrabenazine. Important. Then malignant neuroleptic syndrome is the most fatal out of them. So it can lead to high grade fever, lead pipe rigidity, right? And there is increase in the CPK levels. So what you do immediately, this is a very, very life threatening condition. So first and foremost, you have to stop the drug. Now, because this is because of increase in the calcium release from the sarcoplasmic reticulum, which is going to cause the increase in the muscle stiffness and the contraction. So you want to block that release. And you know that if this is the cell here and this is the sarcoplasmic reticulum, which is going to release the calcium. So here we have the receptors present which cause the release of calcium, and these receptors are called as ryanodine receptors. So when you block these ryanodine receptors, the calcium release will be stopped and this calcium will no longer lead to contraction of the muscles. So what you give here, you give a drug which is going to block this ryanodine receptor, and that drug with us is dantrolene. So dantrolene is a drug of choice, right? Because it blocks the ryanodine receptor 1 and it inhibits. Then we have other drugs. So this is the drug of choice. We can also give bromocriptine. It's a D2 agonist. That you can also. So this is very, very important table of all the EPS because they can be asked like which is the drug of choice for this particular condition. Moving on to the next, which is mania. The topic is mania and we have various drugs used for mania. So we have first important is lithium. Very, very important from examination point of view. So lithium, what is the mechanism of action of lithium? Now lithium is a drug which is going to act at this level that it inhibits the conversion of IP2 to inositol phosphate. So therefore, when it is blocked, it will not be able to release inositol, which is a precursor for formation of PYP2, because then ultimately it is going to form DAG, IP3, etc., and the action is going to come because of this. So what it does, it will stop or it will inhibit the production of the raw material only. So what is the raw material that you're giving? This IP2. This IP is the raw material. So you're inhibiting the supply of the raw material. That is important. But know that the lithium action is not very quick, not very acute. It takes about 2 weeks to produce the effect. So in acute mania as such, it won't be able to stop the attack or take care. But yes, when you start it, it is going to prevent the further attack of mania, and prophylactically it is going to be helpful for us. So this is the important point here, that inhibits the conversion of IP2 to inositol phosphate. ADRs of lithium, very important. So you can remember again a mnemonic. Lithium, L-I-T-H-I-U is here only, and M. So L stands for leukocytosis. I stands for insipidus, diabetes insipidus. T stands for tremors, the fine tremors actually, and these are most common. H stands for hypothyroidism. I stands for I is increase in the nausea and vomiting. And M stands for mothers. So what is in the mother should not be given in pregnancy because it is teratogenic. And it causes a condition in the fetus which is called as Epstein anomaly, which is the abnormal tricuspid valve. Now coming to the maintenance levels in BPD, how much should be the levels, because it has a very narrow therapeutic index. So if you are giving it in acute and maintenance, you have to maintain it within a particular range. So maintenance level in bipolar disorder should be 0.5 to 0.8 milliequivalent per liter, and this should be in acute 0.8 to 1.2 milliequivalent per liter. If it goes high, there will be toxicity, and earliest toxicity symptoms, if you go above some over 2 milliequivalents per liter, you will see tremors also again, but these are actually coarse tremors. Normally you see fine tremors, but they turn into coarse tremors in course of time when we give this. And there can be increase in the nausea, vomiting, diarrhea. So what you do here, the treatment is basically that you are going to give, going to cause diuresis and give sodium bicarbonate. Sodium bicarbonate along with diuretics. If the toxicity goes more than 4, this is an indication for us to start hemodialysis. So when to start hemodialysis? If the levels are above 4 milliequivalents per liter. And another important thing to know is that this lithium is a drug which has anti-suicidal property, which has anti-suicidal suicidal property. From the previous drugs, also clozapine has the same effect, right? Clozapine also has an anti-suicidal property. So also we can write here clozapine. So which of the drugs has anti-suicidal property? Here it is clozapine, and there it was clozapine. Here it is lithium. Now let's do the important drugs, points, or the various phases of stages of mania. In acute mania, the best drugs which we give are atypical antipsychotics. I told you lithium has a lag period, can't be managing the acute phase. So atypical antipsychotics. So we can give olanzapine, right? We can give aripiprazole. You can combine it with benzodiazepines for quick effect. If it is not showing an effect like lorazepam or diazepam, we can give. Prophylaxis, we have to start lithium alongside, right? So oral lithium can be started alongside because it will prevent the further attacks. What if bipolar disorder occurs in pregnancy? So you know that you cannot give any drug in pregnancy. So lithium also has a tendency to cause teratogenic effects. So it is not very common, it's a rare effect, but still we would like to avoid it. And the drug of choice here becomes your atypical antipsychotics. Atypical antipsychotics. In rapid cyclers who have more than 4 attacks per year, the drug of choice is valproate. Which anti-epileptic drugs also can be used? Yes, so we can use drugs like valproate, we can use carbamazepine, we can use lamotrigine. Which atypical antipsychotics can be used? As I told you, we can use olanzapine, we can use risperidone, we can use aripiprazole, and we can use quetiapine. Remember, these are the atypical antipsychotic which can be used in case of mania. These are the antiepileptics which can be used in case of mania. Remember that we cannot give any other drug as such. So these are the important points to be remembered from mania and all the other psychopharmacological drugs. Thank you so much.